The following podcast is part of a certified educational activity titled Achieving Goals in Lipid Management, Then and Now. Access the entire activity and complete the post-test at peerview.com/AKJ860. Downloadable slides and practice aids are also available.
Hello, everybody. My name's Kaushik Ray. I'm from Imperial College London. Welcome to this CME and EBAC accredited webinar called Achieving Goals in Lipid Management, Then and Now. Joining me today are two friends and colleagues, Margaret Lielstedt from Lund University in Malmö, Sweden, and Klaus Parnhofer from the Ludwig Maximilian University of Munich in Germany. So welcome, Margaret, Professor Lielstedt.
Thank you very much, Kosh.
And also Professor Parnhofer. Klaus, good to have you here.
Yeah, thank you, Ray. It's a great pleasure to be here.
Okay, so what are we going to be covering today? Our goals for today are to think about some of the root causes of clinical inertia, and we're going to do that with a couple of cases. And our focus here today is on lipid management. And what we hope to be able to do is equip you with strategies to think about intensifying lipid-lowering therapy beyond statins. And we hope to also provide you with some guidance on how achieving lipid goals in patients at very high risk of cardiovascular events might improve your patient management and future outcomes. Well, if we start by thinking about atherosclerotic cardiovascular disease, it's no surprise that CVD is the #1 cause of death globally. Most of those are going to be from atherosclerotic cardiovascular events. And lipid lowering, whether we think about LDL, non-HDL, or ApoB, we can see from the World Heart Federation cholesterol roadmap, the global burden of disease, that there's a huge difference in these high and low risk countries in terms of average levels of cholesterol levels that are achieved, whether you look at LDL or non-HDL. And LDL lowering is absolutely central to our clinical management. And we can see data from different countries. And here's an example from Germany, looking at essentially how we approach lipid lowering. And you can see that basically the main way we approach lipid lowering is with statin-based monotherapy. And the guidelines and the goalposts have moved between 2016 and 2019. And that same monotherapy-based approach, and particularly in those patients that were at very high risk, secondary prevention patients, might have been successful at the easier to achieve goals of 1.8 in about, or would fail rather in 68% of patients. So only 1/3 would achieve goals. But now when we move the goalpost to 1.8, that's way beyond most statins. And so only now about 16 to 20% of patients are going to achieve goals. So the vast majority are not going to be at goal, if you will. So with that, I'm going to move on to Professor Lielstedt to go through the first case study.
Okay, thank you so much, Professor Ray. We will start here with the case on a patient, a male patient who is 70 years old. He comes into the ER with a non-STEMI, does a coronary angiogram that shows two-vessel disease. Both of these stenosis are stented during hospitalization, and the angiogram also shows generally narrowed calcified arteries. His echo shows normal LVEF. Regarding his background, he is a retired middle school math teacher who recently turned 70 years old. He is married with 2 grown children. He had a minor stroke in 2012. Fortunately, he suffered no physical sequels to this event, but he was prescribed antiplatelet therapy and put on 2 medications for his blood pressure. 5 years ago, he got diagnosed with peripheral artery disease. There was no need for any revascularization, but he was recommended exercise training and put on moderate intensity statins. He's unsure to whether how his cholesterol levels were at the time when the treatment was initiated, but he has been followed in primary care with annual follow-ups since then. He never signed up for these exercise classes, but he goes for 30 to 60-minute walks with his wife a couple of times a week. Quite an easy tempo not to provoke leg pain. If we look at his lifestyle, he's a prior smoker. He stopped 15 years ago. Uses alcohol in moderation. Physical activity we have mentioned. He could do better on diet, particularly fruits and greens. He gets bowel problems with this, so he tries to avoid eating too much. If we go on and look at his lab work at the time of his non-STEMI, he has an LDL cholesterol of 3.5 millimoles per liter. This is 97 milligrams per deciliter. A quite low HDL of 0.9 and triglycerides of 1.6. His HbA1c is 45 millimoles per mole and a random blood glucose of 8.9 millimoles per liter. At discharge, his lipid-lowering therapy is changed to a high-intensity statin, and he receives dual antiplatelet therapy for a year after his PCI. His blood pressure was okay, so no need to change medication there. And he is scheduled for a OGTT in 6 weeks. So we have several points for consideration or discussion here. Firstly, prior to his event, he had a moderate intensity statin of simvastatin 40 milligrams for 5 years. And we can discuss if this was enough given his prior history. Also, he had an LDL cholesterol of 3.5 despite the therapy, which maybe brings attention to adherence and lifestyle. And we could also discuss what more we should do now. Is it enough to switch to a high intensity statin? What are his treatment goals? And so on. We can maybe start if we look in the retrospective, which risk category this patient falls into prior to his non-STEMI. And Professor Parhofer and Professor Ray, you are most welcome to join in here into the discussion. Well, he already had a ASCVD because he has a prior stroke and he has a peripheral artery disease. So I think we can fairly surely say that he is a very high risk patient. And you can think, should we calculate some kind of a risk score to know what treatment targets we should apply or how to go about it? What do you say, Professor Parker?
So I'll maybe chip in and then bring Klaus in. So I think the first thing that you showed very nicely was that you've got a patient who has already had a ASCVD event. He had a diagnosis before this one. And so when their LDL is 3.5 on a statin dose that should give you about 36% lowering, unless there's somebody like an FH patient, you would expect that LDL to be a little bit lower. So you've highlighted adherence as a possible issue. The next thing I think that is really important is, the question about if that person is adherent, going from simvastatin 40 to rosuvastatin is only going to give you about another 16% lowering. And if that person's LDL is 3.5 and they're fully adherent, the chance of getting to that person's goal is going to be unlikely. I think that's the first thing. And one of the things that's very important on this slide is that, again, we should not be thinking about a primary prevention risk calculation. If you're going to do anything, it's secondary prevention. And even though 100 patients like this would all be classified as very high risk, you've just shown very nicely that their absolute 10-year risk could be 20, 30, 40%. The amount of benefit from that level of LDL lowering will be very different. Klaus, anything you want to say?
No, well, I very much agree. And I also think, independent of whether he does not take the simvastatin for whatever reasons, or whether he's taking them and still has a 3.5 millimole LDL cholesterol, it's way too high for someone who had a stroke and PAD in the past, right? And actually, if he was not taking the simvastatin, I would also see quite a high likelihood that he would probably also be reluctant taking the rosuvastatin. And therefore, I think looking back, it's probably was not enough, obviously not enough, but also for the future, I think just switching him to rosuvastatin, I doubt that this will really get him into the goal, to the goal.
And they've got two additional characteristics as well. You highlighted that very nicely. The HDL of 0.9. The average HDL in a white Western male is 1.24, and in females 1.44. So 0.9 gives him a 30% higher relative risk of further events. So, just like we look at the PAD and the HbA1c with pre-diabetes and insulin resistance, this is somebody at higher absolute risk, and that's why you have to be that much more aggressive. But
Exactly. We see from his values from when he was admitted that he at least has pre-diabetes. Very likely that he has full-blown diabetes when we do the OGTT. Also, he had narrowed arteries, calcified arteries on his angiogram, also pointing to the direction of high metabolic burden. But I think it's very good also to highlight this very high risk group. If you actually calculate his 10-year risk, you can do this with risk scores like the SMART risk score. You get a 10-year likelihood of a new event of 50 to 60%. So very high risk is actually very high risk. And this is even before he got his new non-STEMI. He had this high risk even before, having had both a stroke and peripheral artery disease. And if you add on the diabetes diagnosis, it will be even higher. So this is good to keep in mind. If we switch focus to what to do, you have already been discussing this a little bit. If it's enough for us to go over from a medium to high intensity statin at the time of this MI. If we look at recent data from the Sweetheart registry, we looked at the prognosis for patients that were discharged after an MI on a combination of statin and ezetimibe, as opposed to adding ezetimibe later on after discharge, after the first weeks had passed. And we see that there is a definite benefit of starting combination therapy early. And this is irrespective of baseline LDL. So it's important to think to treat aggressively from the get-go for patients that are of this high-risk category. It has not only to do with the LDL reduction, but also, as we have been addressing, to adherence. Starting combination therapy earlier in a closer approximation to an acute event improves adherence. So this is beneficial in multiple ways.
Yeah, and I mean, I remember this study that was very nice data, which really showed so clearly that early and sustained reduction of LDL cholesterol really translates very quickly into cardiovascular benefit.
Yes, it does. And there are more data supporting this finding from both observational and interventional studies to strike strong and strike early as a phrase that has been coined together. So this is something that we definitely should apply for this patient. Here's also a nice slide showing what Professor Ray was discussing earlier. What can we expect with putting the patient on diverse combinations of therapy? And the scenarios are totally different if we think that the patient has been adherent or if he hasn't been adherent. If he has been adherent to his simvastatin, just changing to rosuvastatin will not be enough, or atorvastatin, because then you can only maybe get an additional 6 to 10% reduction in LDL. Not even adding ezetimibe on top of high potentiality statin would be enough for this patient if he has been adherent. But if he hasn't been taking his simvastatin, then maybe you have a window there. As we see that combination therapy with high intensity statins plus ezetimibe can give you approximately 65% reduction in LDL. But then back to what you were saying before, Professor Parhofer, why wasn't he taking his statin? And if he wasn't taking simvastatin, he will probably not want to take rosuvastatin or atorvastatin either. So I just wanted to highlight this, so we always take patient adherence into consideration. We have to penetrate the history and really ask the patient how has it been going, what are the reasons behind non-adherence, and what are the patient's own preferences. If we talk about injectables, for example, is this something that the patient wants to do or doesn't want? Maybe they would rather want tablets, or yeah, there are different possibilities that you could provide this patient, but bring the patient along for the best results.
I think this is great, isn't it? Because I think what you're showing very nicely is that mathematically we've got a lot of data already about combination therapy. This whole rationale of I need to first try and see what's going to happen. If the patient is adherent, you're roughly going to get the percentage reductions that you're showing here. And so you don't have to go through some of these trial and error. And we should be thinking about combination. And, this is something that Klaus, myself, and others have worked on.
Yeah, I think this diagram shows very well a very readable flowchart on how to approach the problem, depending on what kind of risk category you have. And our patient is falling to the category of very high CV risk here on the far right-hand side of the slide. You have, of course, the target of less than 1.4, and you should definitely start with a combination of statin plus ezetimibe plus even bempedoic acid or some kind of combination of these three drugs. And but in the case of the patient, maybe if we assume that he has been compliant, maybe we should start thinking about PCSK9 inhibitors earlier on, even at the time of his event, if that's possible. Of course, the rules are different in different countries, which has been taken into consideration. Some are stricter than others on that you have to try a tablet first before going to the next line treatment. But he inevitably probably will have to start PCSK9 inhibitor treatment if he has if we want to get him to go.
Yeah, I very much agree what Professor Ray said before, that in these very high-risk patients, we have to move away from doing it very slowly, stepwise. We have to get into quick and fast and a sustained reduction of LDL cholesterol. And that usually means that you have to use combination therapy. And I think that also applies to first presentations where people were not taking anything before, that they should really be started on combination therapy. And I mean, again, you in the Sweetheart study have shown this so nicely that this is a very successful strategy.
Yes, I think this sums it up quite well from the first case study, and we should be able to move to our second case study, Klaus.
So I would also like to present to you a case. It's a 41-year-old man, recently prescribed high-intensity statin therapy. Also, his hypercholesterolemia was already diagnosed about 10 years ago in 2014, and his LDL cholesterol was 6.6 millimoles per liter, or 257 milligrams per deciliter. At that time, his maternal uncle was diagnosed with an MI and had a very high LDL cholesterol, and therefore the family was screened, and his mother had an elevated LDL cholesterol, and he himself too. So he and his mother were put on simvastatin, but he was only taking this not very regularly because he was mostly afraid that this could interfere with his muscle strength when playing soccer. His mother took the simvastatin and decreased her LDL cholesterol from 280 to about 180. But then about 10 years later, she had a severe myocardial infarction. And at that point, the 40-year-old man was switched to rosuvastatin 40 milligram. And with that, he had an LDL cholesterol of approximately 110 milligrams per deciliter, but he did not tolerate that very well because he had muscle pain. And that's why he came to the office. And so he now has an LDL cholesterol for around 107 milligrams per deciliter. And so the question now is, what should we do more? Should we do some imaging studies? Should we do more lab values? And maybe, Professor Ray, you want to comment on possible imaging studies that you would suggest or not suggest in this case? And maybe also then we can discuss a little bit of the more further lab values need to be determined.
So thanks, Klaus. Thanks, Professor Parnoff. And so one of the key things I think here is with looking at the biochemistry, one would think obviously about, particularly with the parent as well, and the extremely high levels in your mind, FH is going to be high on those risk of probabilities. And the one thing to actually think about in these individuals is the average age of diagnosis of FH globally is 44. So that means that's 44 years of missed opportunity and exposure. It's like smoking for 44 years, and then you're finding somebody like that. So in those individuals, because it's not just about the LDL, there'll be other factors that accelerate this, that may slow this down. And often we might, whether it's for a reimbursement purposes or sometimes to motivate the patient, because a lot of these people feel absolutely fine. And often their GPs have said to them, if they're young, oh, the LDL's high, don't worry about it. And all we do is wait 10 more years and they've got disease. So if you are going to use imaging, then there are basically two approaches one thinks about, either the carotids, and if we're using imaging of the coronaries, then probably that gives you better reclassification. So carotids, 4% of people will be reclassified. You use CT coronary artery calcium scores or angiography, maybe about 20%. So that's better. But that might help you then drive or get access to treatments that would bring that make them eligible for sometimes therapies like PCSK9 guided therapies that are restricted. So those are some of my thoughts. But Margaret, what do you think?
Yeah, I agree. Of course, it also is a question about accessibility. What type of studies do you have a possibility to send your patient to? And also reimbursement here. I'm guessing that it's not the same in all countries if you are allowed to screen a patient like this with a CT, for example. So that's possibly something that you would need to take into consideration. But otherwise, both for reclassification and also I think it is very good for motivational purposes to be able to see a little bit better if the high cholesterol levels have started to affect the patient's arteries or not. That's a very strong motivational factor for further
Yeah,
treatment.
and I mean, to a certain point, it will determine the goal that you're trying to achieve, right? So, I mean, if you see by whatever means any atherosclerotic disease, you will go deeper with your LDL cholesterol.
And also the other way around. I mean, there are patients or people, these of course are healthy people often that have high LDL levels, but then they don't have any atherosclerosis. And a young person that has not developed any atherosclerotic plaques despite having a high LDL, maybe it's you can withstand therapy for that individual instead of proposing a lifelong treatment to that person. So it goes both ways.
Yeah, but probably with this level of LDL cholesterol, you would have a very, very hard time of
Yes, of course.
withholding
And with his
therapy.
family history as well. I agree.
But I mean, the imaging part was the one thing. The other thing was also what kind of other parameters we should measure. And I think in this person, a person like this, it would also be very important to measure Lp(a), and we probably would also measure CRP, because these are somehow risk enhancers and would probably then still lead to probably a more aggressive LDL cholesterol reduction. And when we actually found an elevated Lp(a) of 110 milligrams per deciliter, which is a significant risk enhancer, but he did not have any elevated CRP. And coming back to the imaging studies, we saw some plaques on the carotid ultrasound, because that's currently what most people do here, mostly due to financial aspects, that they use this as a primary imaging study. So, of course, as Professor Ray mentioned, this is very likely. It is a case of familial hypercholesterolemia. This brings up the question, who else should be screened? Margaret, who would you screen?
Of course, all his first degree relatives, siblings, children.
Yeah, I mean, and actually, it was done when his uncle had this infarction, but somehow it was not then followed up consequently. So the first step of screening was done, but that not really the second one.
But did they do any genetic testing, or was it only lipid levels that were
No, it was only lipid levels
okay?
that were
Mm.
done. And actually, the screening landscape in Europe is quite variable, with some countries with very good testate and genetic screening, and other countries where there is much less screening be done. Although this, I think, is a very, very important aspect, because we have moved to the cumulative LDL cholesterol as being the major risk factor for cardiovascular disease. And obviously, just as Professor Ray said before, if you have familial hypercholesterolemia, you have an elevated LDL cholesterol over a very long time, which then, of course, gets you into an area where you can develop cardiovascular disease much earlier than a person who only develops LDL hypercholesterolemia at the age of 50 or 60. And that's why I think screening at an early age is very, very important, because that also gives you then the opportunity to decrease it at an earlier time point, and thus preventing that this accumulation occurs in such a bad way. But I think we have to become better with respect to screening and treating these people earlier. And coming back to this patient, because he had some form of statin intolerance, we would probably still use or try another statin, again combine it with ezetimibe. And now currently our next step is usually also for regulatory reasons to add pempedoic acid. But with this level of LDL cholesterol, this is probably not gonna be sufficient to reach the goal, and we would probably in such a person use combination therapy using an PCSK9 injectable to achieve the goal. I'm not sure whether you would do it differently, Professor Ray or Professor Leostot here.
I think this person is so far away that based upon what we know of the percentage reduction, so you've already said that you've got a atheroma. This is an FH patient. You've got a high LPA as a risk enhancing feature. So a bit like the first case, that we can lump them together into a qualitative group, but the absolute risk when you add all of those up is really high. And mathematically, it's going to be pretty unlikely you're going to get to goal. So for me, a PCSK9 would be very high up alongside at least a statin and ezetimibe.
Mm, the same here. Where I work in Sweden, the subvention rules are that you have to try the statin first, then the ezetimibe before prescribing PCSK9 inhibitor to a patient like this. But I think it's very important to get the patient on board from the beginning. and say, okay, we will start with a combination of a statin and ezetimibe, but I am 99% sure that this will not be enough. So, and we will double check your values in 4 to 6 weeks, and then we will add the injectable. So the patient is on board from the beginning that this will happen. It will probably be beneficial for adherence if they have the plan from the get-go. So it won't be a disappointment that the values haven't gone down on the first set of tablets.
No, I very much agree. And what we also try to do to make the patients clear what is really the goal LDL cholesterol, so that they also know whether they are far away or close to the goal, because that also helps, just like the imaging study, if the patient is really involved in the treatment, that helps with adherence dramatically.
I also think it's very important to take discussion about the area under the curve with the patient, because many of my patients react to, oh, I mean, my value, I see it, the reference value is way below. Isn't it dangerous to be so low? And why does it have to be this low? Isn't it enough to be just 1.3? To describe this, okay, you've had your high levels for all these years, so now we want to try and decrease the area under the curve, so your totally accumulated LDL will be lower. People get this, so if you take some time to explain it, it usually increases adherence to therapy.
I very much agree. And I think this ends this case, and I give it back to Professor Ray.
Great, thank you. So what you both basically very nicely shown is kind of where we are right now, but also thinking about where we might need to think about in the future. So clearly, there are patients where even with 2 oral agents that we have, or sometimes even 3, we're going to need other pathways. And one of the key things to think about, I try to explain to my patients about combination therapy, is pretty much most of the things that we have increase the LDL receptor production expression. But we have therapies that target PCSK9, and these help keep whatever LDL receptors your body makes, you enhance, survive longer. And of these, the approaches that we've had in the past are monoclonals and siRNA based approaches. But we are seeing the emergence of other therapies, and these may be oral small molecules. And there are 2 certainly in the pipeline. One's a macrocyclic peptide taken daily, one is a small molecule. These are all investigational therapies. And in fact, in the future, we may have the opportunity to think about base editing or gene editing, where you can effectively create a loss of function in PCSK9. So we've got a number of approaches that are emerging and that we may well have in the future, but we've got some key things that we need to think about right now. So key take home is that both cases that we've seen talked a little bit about an opportunity to do something better earlier. So most of the things that we're thinking about in terms of patient care, our patients are largely asymptomatic until they aren't. And that can actually lead to clinical inertia. So think about global risk, think about a life course, think about risk enhancers. And your LDL effectively has to be right for your level of risk. And LDL lowering is central for a lot of these things, but other risk factors are. And I think, a bit like blood pressure, we've seen that as we've moved the goalposts, and for these, for example, very high risk patients, we've moved from 1.8 to 1.4 millimoles per liter, for example, that inevitably means that 80% of our patients will need some form of combination therapy. We have a number of pretty good oral treatments, statins, ezetimibe, bempedoic acid. Right now, we've got 2 injectable therapies, monoclonals, 26 injections per year, and we've got a twice-a-year injectable siRNA and inclisiran that can be used as part of combination therapy. And we've got a whole host of other things that are coming up down the pipeline. But the key thing for our clinicians is really to remember that we have those, and they only work if we actually use them when we think about risk in our patients. So with that, I'd like to say thank you to both of my colleagues, Professor Leostatir, Professor Parnhofer. Thank you both for joining. Very interesting cases, which I think everybody will have found helpful. Thank you to both.
Thank you very much for a nice discussion.
Thank you, Tosh, for that very nice discussion. Yes.
And just a reminder for our audience that the slides will be available for you to access and download. And we hope that you enjoyed the session and enjoy this CME. Thank you for listening.
Thank you.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an educational grant from Merck Sharp Dohme LLC, a subsidiary of Merck Co. Incorporated. To access all materials for this activity, visit peerview.com/AKJ860.